Welcome to today's webinar presented by supercoder.com. Supercoder.com is an online coding solution offering Part A and B coding reference tools, resources, and not more than 30 specialty coding and compliance newsletters from the Coding Institute in one site. I hope you enjoy this short session.
Two disciplines relate to each other. And so that's really what we're going to dig into in today's hour presentation. And I'm going to just guide you through the slides, the handouts, as we move along. So moving to slide 2, let's start off today's program by setting the framework for the difference between the roles of the social worker and the nurse case manager. Having done quite a bit of work in a variety of organizations across the country, I'm always a little disheartened when I hear that the social workers and the nurse case managers are performing the same functions, because at the end of the day, the truth is that we do have different but complementary skill sets, and we bring to the table, to the interdisciplinary team, those different skill sets. I think the challenge for us is to figure out, for our case management departments today, how we can truly optimize the skill sets of each of these disciplines. And today we're going to go through exactly what I mean by that. So we know we are different, and yet we do have some overlapping areas of responsibility. But the question becomes, as you move to slide 3, how do we really figure out how best to integrate the two roles and really take the existing resources that we've got in our departments and use them to the advantage of the department, the patients, and the organizations that we work for. This is a challenge, and it's something that many organizations are struggling with. So let's kind of go back in time a little bit, slide 4. If you think about the beginning days of case management, particularly going back to the 1980s, the mid-80s, when we saw the beginning of the DRG, or prospective payment system, and that was the point in which case management moved from what was essentially a community-based model, and it moved into hospitals and acute care settings in response to the changes in reimbursement related to prospective payments. So if we think back before that time, when we were in a strictly fee-for-service environment, we really were rewarded by our third-party payers for long lengths of stay and high resource utilization. These traditional models were fragmented, and roles and functions of the entire interdisciplinary team were very siloed or compartmentalized from each other. Due to this fragmentation and lack of integration, we saw the cost of health care rise and rise through the 70s and early 80s, and of course we know that it was those rising costs that led the government, the federal government at that time, to change the reimbursement structure. So if you think about, on slide 5, all the fiscal incentives that kept us in those old models, it really sets the framework for why things had to change in the mid-80s. So again, longer lengths of stay meant more money, more reimbursement to our organizations. So if patients came in for 3 days for preoperative clearance and then had their surgery and then remained in the hospital for their recovery period, that was all unquestioned, frankly, and reimbursed. And so patients did stay in hospitals until they were completely recovered and went home. Social work looked at patients on a referral basis, usually helping patients cope with issues of social dysfunction, or if the patient had a life-altering medical event, and the social worker would try to work with that patient and family. There was some discharge planning done by social work prior to 1985, particularly as it related to the movement of patients to long-term care settings and sometimes home care, depending on how the work was differentiated.
Supercoder is the fastest-growing online reference tool with more than 25,000 subscribers. Call 866-228-0000 888-928-9252 to get a free product demo or sign up at supercoder.com for a 7-day free trial.